Back with more incredible information for us about ER visits is Dr. Mark Korson of VMP Genetics. Dr. Korson is board certified as a clinical biochemical geneticist and has extensive experience in the diagnosis and management of children and adults with a wide array of inborn errors of metabolism, specifically mitochondrial and metabolic disorders. Dr. Korson promotes an educational approach to address the growing crisis in metabolic health due to the shortage of available clinicians to treat this patient community. He continues to develop innovative resources to help educate medical specialists and their trainees so they can participate in the diagnosis and management of metabolic disease. Good morning, Dr. Korson, and welcome back.
Thank you so much, Kara. Again, a pleasure to be here on this Sunday morning. And so this is taking a different tack. This is not as much of a session on facts. It's more a session on strategies and emotions and navigating the system. So let's begin. So in a perfect world, let's talk about a perfect world scenario. And of course, nothing is perfect, but go with me on this. So you're concerned about your 6-year-old child, Karen, who has MCAD deficiency. She's had a low-grade fever, a cough, and a runny nose for 2 days. Karen hasn't eaten well for a day already, and she is less interested in eating today. She has been only drinking juice. She also seems more listless. Today is Sunday. You are uncomfortable just watching Karen at home and want a doctor to check her out. Of course, the clinic is closed. You decide to take her to the local ED where she has been evaluated before. Before you leave, you make sure you have 2 copies of her ER protocol with you so that if one doctor takes it, you always have something available if someone else needs to see it. Karen falls asleep in the car on the way to the ER. The ER is not very busy at 11 a.m., and it takes only 20 minutes to get into an examination room. Karen is crying now, but no tears are coming out. The nurse checks her vitals, and her temperature is 100.8. You provide the nurse the ER protocol, who will share it with the doctor. You also mention that Karen has been evaluated before in this ER for the same concern. The doctor comes in 15 minutes later after having reviewed the protocol and the summary note of Karen's last ER visit. She takes a history and asks about your concerns. She then performs an exam. Afterwards, she reviews the protocol again. The ER doctor is concerned about Karen's lethargy and the fact that she is not well hydrated. You mention that she seems worse today than the last time she was seen in the ER. She says, that's the doctor, that based on the ER protocol recommendations, she wants to run a few tests to check Karen's glucose, her lights, and so on, and a throat swab will be obtained because her throat is red. She adds that when the blood is being drawn, she would also like to place an IV and start running fluids to improve Karen's hydration. The sugar in the IV is necessary as well. They'll be using a higher glucose solution as recommended in the protocol. Within about 5 minutes, the nurse comes in to draw the blood and place the IV. Karen is upset and crying appropriately, but the blood is drawn quickly and the IV is placed. The nurse takes a drop of blood that she took for the blood draw to get sent to the lab to measure the glucose at the bedside. It is 88 milligrams per deciliter. So sort of approaching borderline, but still not hypoglycemic. The IV fluids start to run. You notice the IV bag reads 10% dextrose with normal saline. Over the next hour, the nurse checks in every 15 to 20 minutes to see how things are going. Karen fell asleep after the IV was placed. The doctor comes in about an hour later with good news. The blood results look good. Karen is not hypoglycemic, as confirmed with the blood sample at the laboratory, and she's not acidotic. However, based on protocol recommendations, she would like Karen to continue getting the IV fluids. 3 hours later, Karen is awake and looks better, but she has no interest in drinking anything. The rapid strep test is positive. So she has good reason to have a red throat, and that may be interfering with her swallowing. The doctor is afraid that Karen will not be able to take in enough fluids and or food in a consistent way at home over the next day or two. And she's afraid that Karen will bounce back into the ER. She also says that there's going to be a lot of pressure on you to make sure she takes in enough around the clock. The doctor proposes that Karen be admitted to the hospital for IV fluids and to get adequate glucose in the IV. She'll get antibiotics for the strep throat. She asks if you have any questions. Now, no one likes to have their child in the ER setting, but that is part of life when you have a fatty acid oxidation defect, or you have a child with an FAO defect, or any number of acute metabolic disorders. And it would be nice if ER visits went somehow along this way. So what makes this a good ER experience? Oops. Here, in this situation, in this example, things happened in a timely way. You know, you weren't waiting for hours. And of course, that it makes sense if you can to choose times, if you have to go to the ER, choose times when the ER is not going to be very busy. That tends to be in the morning, over the afternoon or the evening. Often people will wait till they wait to go to the ER until they get home from work. That's when they hear from the babysitter or from the school that the child has not been well. And if you have to go on a weekend, also go in the morning. ERs are busy places in the evenings on weekends. What else made this a good ER experience? The staff asked about your concerns and input. So, too often doctors try to get to a diagnosis within the first few seconds of what you tell them. And they try to lock into a management plan. But if they take the time to ask about your concerns and get your input on their plan, that is both reassuring that they're listening to you and that it's going to be an agreeable management plan. The staff do their homework. So reviewing the last ER note and paying attention to the advice of the experts, recognizing that they themselves don't have an expertise in this area. So they're relying on the representative document from the experts. And the staff tell you things that you have probably heard before from your own doctor. So what the doctor said in this particular case scenario is something that I would say to you as a patient or a parent, taking precautions. Perhaps most patients who have fatty acid oxidation defects don't necessarily get admitted because they're in a crisis, because this child is not in a crisis, but left to herself. And if she stayed at home, she would tip over into a crisis. And then you have a lot of mopping up to do, and it's a more dangerous situation. The mother in this situation, the parents in this situation were properly prepared to recognize the signs that are potentially dangerous. That Karen is sick, that Karen is not eating well, and she doesn't look like she is going to eat well anytime soon, in which case she is going to get into trouble. It's only a matter of time. When she's going to get into trouble. So let's head that off. And that's why this is and that's often where children are admitted to hospital. It's to head off that kind of a situation. So the protocol is a very important document. And there are certain attributes that make a protocol effective. One, it should assume the reader is not familiar with fatty acid oxidation defects. So, throwing around terms like acyl carnitine and hexanyl carnitine and, things that a metabolic doctor will know, but a non-metabolic doctor has no idea what you're talking about, in which case you can still use those terms, but explain those terms. Two, it explains the issues clearly and in a language the reader understands. So this is an AR protocol, highlight the things that an ER physician is going to be concerned about, is going to pay attention to. Offer practical advice that's open-ended but not vague. So yes, it's useful to say that this patient needs glucose, but the ER physician may not recognize that it's important that in these cases, it's important to suppress catabolism, because fatty acid oxidation is a catabolic pathway, is a pathway where that patients use when they don't get enough calories in from the outside, as is the case in this scenario. So an ER physician may prescribe 5% dextrose, not recognizing that 10% is actually more effective in suppressing catabolism and ensuring the safety of the patient. And do it in a stepwise fashion. If you order a blood glucose level and the glucose level is low, push an amount of high dose glucose followed by a glucose infusion. If the patient's blood glucose is normal, then start with the infusion at this rate, despite the absence of hypoglycemia, because we were trying to suppress catabolism in this patient. And of course, all protocols should end with a name, a signature, a contact number, and a date. You can't, without these, any medical provider is going to wonder how specific this protocol is for the patient. And so it's important to get that extra information there, again, with a contact number and date. Otherwise, it may be put aside. The objectives of an emergency protocol is to provide essential information. The protocol should teach a little bit about the essential points regarding an FAOD. It should inform. It should direct in terms of what to do, and should scare a little bit, using terms like coma, using terms like sudden death. It's not to scare you as parents or patients, but it's used to emphasize the seriousness of this situation, so that doctors who don't know about these disorders are going to act effectively. And the emergency protocol should reassure that there is a person who, if you call them, will back you up, will give you more information about this particular ER scenario and how to get the patient through it. So the contents of an emergency protocol includes information about the disease, what a sick patient, and some protocols are specific to the patient, saying how the particular patient looks in a sick situation, what to look for in the assessment of such a patient, the test to do, first-line treatment and why, and again, contact information. So there are protocols out there. One example in the internet. One example is on the website for the New England Metabolic Consortium, which offers a lot of information, including acute illness protocols. And here are the 3 protocols offered for fatty acid oxidation defects for patients with VLCAD deficiency, LCHAD, and MCAD. And it lists a lot of the information that we have been talking about in order, including introduction, pathophysiology, biochemistry, test to do, management, and so on. But it's a good protocol, but the protocol is not intended, as it stands, it's not intended for the ER. It is intended to give your physician a template to use, and this forms the basis of an ER protocol for you as a patient or your child as a patient. But then things need to be added to it, like your name, your date of birth, whoever the physician is, and the contact number along with the date. So this is meant to be used as a resource to generate an ER protocol, but don't use it straight, because it most of the time will just be disregarded. All right, so we're talking about a perfect world situation, and I guess if it were a perfect world, then I could end the talk right here, but it's not a perfect world. The challenges in an imperfect world are that fatty acid oxidation defects are rare. Metabolic disease teaching is in medical schools, and specialty training after medical schools is poor at worst and inadequate at best. And exposure by specialty trainees or postgraduate so exposure to metabolic patients is limited. And so, unfortunately, the majority of medical trainees don't know about these disorders, and so, or know about these disorders because they read that chapter in the textbook during medical school. But the bottom line is they don't know about your disorder, and they are meeting it for perhaps the first time when they see you, and that's a problem. The challenge is the physicians. The physicians that you meet are busy, and they're getting busier with enormous pressures in the hospital. I mean, just think over the last year when COVID dominated the medical scene, they were overrun by medical emergencies. And yes, the fatty acid oxidation defects and the potential crises that happen with them are important. They're dangerous. They're important to take notice. On the other hand, when you're dealing with 50 other patients who are having trouble breathing in the ER, you can imagine the pressure that these medical providers were under. And communication between doctors in real time is a challenge. That sometimes things don't happen, or worse, things happen badly because doctors don't communicate. Also, physicians are human. And that's truly unfortunate. It would be, in some respects, I guess, for effective therapy, it might be better if physicians were robots. On the other hand, physicians are human, and that provides the personal attention piece. It provides the bedside manner. It provides the human compassion, and that's obviously are incredibly important parts of medical care as well. But physicians are human. And the negative aspects of that are they may not feel comfortable when patients or parents know more than they do. Some really get intimidated by that and they shut down, and it's really unfortunate. Or they may not deal well with patient frustration and anger, and they rear up and they get very defensive. And then the reason why you're there is to focus on on helping your child or yourself is lost because of the bad dynamic. Some physicians don't communicate well, and some may be frankly arrogant. And then the system in healthcare, in hospitals, especially academic medical centers, is complex, and it's only getting more complex. And this is unfortunate when you already have a rare and complex disorder, especially when there are lots of doctors or services involved. So I'm going to tell you about a few stories. These are all real stories. They are not all restricted to the ER setting, but they offer useful points to think about regarding how to advocate or how to advocate better. During the time, if you would like to write your own situation or your own question, use the chat box and we'll discuss it afterwards. So I'm going to tell you about Chris, who is a little girl very much like Karen that I told you about, who had MCAD deficiency, was brought to the ER, and things were going well until Chris was found to have a blood sugar level that was normal. And it was, I don't know, it could have been 100, 110, but intake had been poor, and the doctor got really focused on hypoglycemia. Hypoglycemia is a problem in MCAD deficiency. Beware hypoglycemia, treat the hypoglycemia. So when the doctor didn't realize that it's not just hypoglycemia, it is the problem with catabolism, that if this child doesn't eat, doesn't drink, then she is going to become more dependent on fats as a source of energy, and that's going to fail her. And unless you turn that around and provide glucose, she's going to get into trouble. But all he was focused on was the hypoglycemia. This child is not hypoglycemic, therefore does not need IV fluids, and therefore can be discharged from the emergency room. And the child was discharged. Fortunately, nothing bad happened. The child did demonstrate adequate amount that she was drinking adequately. And so at the expense of the parents' nerves, that child was treated at home with drinking regularly throughout the following night, and then her intake picked up the following day. But that was chancy. That was risky. What if Chris had not improved her intake? That would have meant a repeat visit to the ER, maybe that time with actual hypoglycemia. So that was an unfortunate situation. So this is, I will call that case one, Chris and the unfamiliar doctor. Case two is Kerry. Now, Kerry actually doesn't have a fatty acid oxidation defect. Kerry has an organic acidemia. So it's a different kind of disorder, but is similar to fatty acid oxidation defects, that when Kerry is in a situation where he is not taking in adequate amounts of calories, he is going to get into trouble. And he gets into trouble in a little bit of a different way than a child with a fatty acid oxidation defect. It's actually perhaps more serious because it's not just sugar that can drop. The blood becomes very acidic. The ammonia level, which is a neurotoxic agent, rises. And it's a very complex medical crisis. Anyway, Kerry was born and got into trouble as a newborn because of this disease. The particular disease, methylmalonic acidemia, was not included in the state newborn screen at the time, so it wasn't suspected. But Kerry got into trouble, and because of the good work of his treatment team in the newborn ICU, his diagnosis was made within about 7 or 8 days, which is great. But still, Kerry had a hard time in the newborn period, and ended up having some problems with low muscle tone and some delay in his motor development. He learned to walk, but it took a while to get there. His metabolic team gave Kerry's parents an ER protocol like we described before, and periodically Kerry would get sick with an infection, with a fever, and the parents took him to their community ER, and the ER was very good about following the recommendations, and Kerry weathered a number of these crises without ill effect, and the parents felt very comfortable taking him to the community hospital. But then one time he was a little bit older than 2. Kerry gets sick again, shows up in the ER, but it's a different ER physician, new on staff, who was actually quite intimidated with this diagnosis, did not read the protocol well, ended up trying to do her own reading on the internet, which was, who knows whether it was up to date, who knows whether it was specific. And Kerry at that time was rather dehydrated, I guess perhaps because he was vomiting. And so his blood acid level was quite abnormal. But the ER, now that is common in organic acidemia crisis because the organic acid accumulates and it results in a blood acid level that's high. And but the ER physician insisted, well, we see this with dehydration, that she thinks that she said that just giving IV fluids will be enough to correct the acidosis. Now, the parents knew something of methylmalonic acidemia. They said, no, you really have to give supplemental bicarbonate. And this struggle ensued between the physician and between the parents. And the doctor insisted, no, I'm not doing that. There's no reason to do that. We're just giving fluids. The parents became irate. The father really got angry, so much so that the physician called security to escort the father out of the emergency room. Well, this is a parent's worst nightmare. You know what your child needs, and you can't get it across, and your child is in danger. Well, 6 hours later, after getting IV fluids, not only did the acid level not correct, it got worse. And 6 hours later, Kerry started writhing on the bed. So in writhing movements. And the reason he was writhing was because some of the deep nuclei in his brain were infarcted. He had a stroke because of the acidosis. As a result, Kerry lost the ability to walk. And that is a truly unfortunate situation, a tragic situation that was preventable. I will call this case Kerry and the Arrogant Doctor. Case 3, Sana. Sana was referred to me because she had probably 3 to 4 months of age, because she had failure to thrive. Questioned whether she might have a metabolic disorder. And she had had an episode of pneumonia, and then she went on to have another episode of pneumonia. Anyway, she was referred to a pulmonologist in the community setting who was present around the time of the second pneumonia and had drawn an aspirate, like a culture of phlegm in her trachea, and it was positive for Staph aureus. Now, some patients, so here you have a patient with failure to thrive with pneumonia, and it was positive for Staph aureus. Well, that could be a picture of a child with cystic fibrosis. And this was actually before CF screening was done for newborn screening as well. And so that doctor felt that this patient could have CF, and so sent her for a sweat chloride test, which was borderline. So he sent off DNA testing, which is actually very sensitive, but the DNA testing came back negative. He thought, gee, this is a weird situation. I'm going to refer Sana into the hospital where I was working, to the pulmonologist there for a second opinion. And that pulmonologist said, no, I don't believe this patient has CF. Meanwhile, the original pulmonologist said, well, I understand, but I still a little concerned about it. Anyway, Sana comes down with a gastroenteritis, with vomiting, diarrhea, around 6 months of age, and she comes to our hospital, to the ER. And the intern takes a history, and in the review of systems, anything else that we should be concerned about? And the mother said, well, there's a concern that Sana has CF. Okay, so the intern calls the pulmonary doctor at the hospital, who says, she does not have CF. I told the mother that. That mother is fabricating symptoms. And the Department of Social Services were called to get involved. Now, the DSS, heard the situation, called out the different doctors. But for 24 hours there, Sana's mother was terrified that Sana would be taken away. Now, the problem in this situation is every doctor is entitled to his or her own opinion, but where there's a conflict, it would be really good for the doctors to talk, because that mother was left in the middle of two opinions. And what parents will do is that they will hold on to the more severe scenario because they don't want anything to be missed or to be overlooked or not treated. And that is completely reasonable. And if the doctors had spoken with each other and come to a consensus and offered a unified opinion to Sana's mother, that would have clarified it. Instead, we made this mother crazy. We, the medical profession, made this mother crazy and put her in a dangerous situation. I will call this case Sana and the Uncommunicative Doctors. And then finally, I'm going to tell the case of Mark. Well, the Mark happens to be me. And I'm not the patient here. I'm actually the patient advocate. But my mom was 90 years old. She was in good health, not taking any medications, living on her own, driving. But I live in another city. And my brother called my mom one morning, and she didn't respond. So he went over there, and my mom was unconscious on the floor. She was taken to the ER. The ER, she was found to be in kidney failure, and she was admitted to the ICU. And so I flew up, and she turned out, she was in kidney failure because of the onset of cancer. All right. Anyway, she was discharged from the ICU setting to the ward, and I was there for that. And I was, the delegated patient advocate. I mean, that's a role I take on readily. And so I'm sitting there waiting to meet the internist on the floor, because I want to introduce myself and because I want to get information from him. And and I usually don't tell people I'm a doctor unless I have to. And so I want to suggest to him that I'm a physician, because I mean, so he knows who he's talking to. Anyway, so I asked the floor nurses, when does, we'll call him Dr. Smith, come around? And they say, oh, he comes around, but usually in morning. So I was there at 6:30 in the morning waiting, and I was prepared to stay there all day. And sure enough, Dr. Smith comes around and he talks to my mom, and he asks questions, and he examines my mom. And then we start to talk, and I say, by the way, I'm going to be here for the duration of my mom's hospitalization. What time do you round? Because I'd like to be here when you come around. And he said, well, I don't know why I come around. And sometimes it's in the morning, sometimes in the evening. And if you're going to want me to go through all the labs from the day, I'm not going to do that. That's not my job. And it goes on and on and on. I was, whoa, boy, he's aggressive. And then so I could have taken an aggressive counter stance. I'm a physician, and reading my rights. And then I thought, gee, I don't want him to take out his feelings about me onto my mom. So I have to treat him well. On the other hand, from what I hear, he's a very competent doctor, so I could use that competence for my mom's health. But how can I get the other things that I need? Where am I going to get the lab results? Okay, well, I figured out actually one of the specialists was good about that. I can get it from her. And I sort of had to figure out how to sort of navigate this situation, which was presented to me. And I decided, okay, I'm not gonna start a fight with this doc. I'll make this work. And I was able to do that. Now, granted, I'm a physician. I know this system. I know how I can manipulate the system. I'm in a better position than you as patients or you as parents. But sometimes you can manipulate the system to make things work, even though what should work is what should happen is a doctor who is compassionate, who has good bedside manner, who answers the questions, who doesn't make you feel guilty for asking things. Even though that should happen, sometimes it doesn't. And I will call this Mark and the doc with attitude. Okay. So having said Mark and the doc with attitude, I will admit that some patients and caregivers are in fact challenging. They are demanding, or they may be aggressive. So, sometimes, especially when you're dealing with a metabolic disorder or a complex disorder, doctors will say they pay too much attention to medical details. Well, of course they do. These are rare disorders. No one else knows about them. So, of course, the parents and the caregivers pay attention to medical details, because if they don't, they want to make sure everything is covered. But it's very hard. And I remember being with a patient in the clinic. And of course, sometimes patients yell at you, right? Or patients or parents yell at you. And I remember being in the clinic thinking, this mom is yelling at me. And then I realized she's not yelling at me. She is so frustrated with the system. She is so frustrated in the challenges offered by the system, the obstructive things that happen in the hospital. And she is venting. And I just happen to be the person in front of her. And she's yelling at me. And when I realized that you had nothing, and I actually asked her, she says, no, I'm not angry with you. I realized it's almost never to do with me. I mean, if you're doing your job, and you're listening to the patient, it's just their frustration. And so it's important for physicians to learn not to take things personally. Look how complex things are in a hospital. So getting back to what you can do then. In the ER setting, step one is to provide a protocol. You can show up in the hospital without a protocol, but you're really taking a risk. It also puts you in the situation while you're either nervous about yourself or about your child. you have to start teaching some unfamiliar doctor, and it could be a medical student who sees you first, who then a resident, and then the doctor. You're telling multiple people, you're teaching about the disease, and you're teaching about what to do. Meanwhile, you're the parent. You're sort of just concerned. So bring the protocol to do the teaching and the advising. Step 2 is if the doctor isn't listening, or if you're worried that things are not happening the way they should, then give the ER doctor the name and phone number of your metabolic doc. Now, that should be in the protocol, so it's just directing him or her to look at that. If the doctor won't call and you're concerned, then you call the metabolic doc with the name of the ER doc and the ER phone number. And if I hear from you, and then I will call the doctor and I will explain the situation, and I will start throwing around words like sudden death and coma and cardiac arrhythmias, and use the words that will get him over to my side and do what needs to be done. But if you've had bad situations, then sometimes what can be helpful is having the metabolic doctor call the ER ahead of time before you get there to set the tone and the expectations. And that will take the pressure off of you to teach and to highlight the important points. In the hospital, so that's in the ER setting. In the ER setting, it's a little bit more straightforward. It's either the ER doc, you're not dealing with the whole hospital, you're just dealing with the ER doc or the ER team, and you're sort of you have one step away from your metabolic doc in the clinic. But once you get in the hospital setting, it's more complex. You're already dealing with the hospital system. Your metabolic doc is a little farther away. And so to help you out, utilize different providers on the team to get information or to help, not direct care, but get your points across. So not just the doctor, but perhaps the nurse. If there's a patient, a play person who works with children, they are often connected to the social worker on the team. That can be a good way of getting your point across about your anxiety, your worries. The other point is call your metabolic doctor, to call the treatment doctor, the attending physician. If there are multiple doctors involved with your care or your child's care, then ask for a team meeting where, especially if you're hearing different points of view, different recommendations from different doctors. And it's not that you're in the middle, but the attending team is in the middle. And if you don't understand things, a team meeting forces everybody to the table to talk about, and again, come to a consensus of what is best for your care, your child's care. And also, if you feel you're not being listened to, all hospitals have patient liaisons who will intervene if you're not getting questions answered. They will ask the physician to pay more attention to that. So just some general rules of engagement, though, when you're talking to human physicians, is one, remember why you are there. If you're dealing with if you're in a situation where it's getting heated, remember you are there for your child's care. You are not there to win an argument. You are there for your child's care. Be clear about what you are concerned about. So, sometimes focus the nature of the concern. So in other words, yes, your child has had trouble with failure to thrive for 6 months. Yes, your child has intermittent vomiting. Yes, but why are you concerned? Why did you come in today? Because you don't want the focus of the concern to be lost among all your concerns. How can this doctor help you today? So try to prioritize your concerns. And be careful about verbally conveying information from another doctor. So, yes, you can say that, well, we saw Dr. So-and-so and he said this, and then we saw Dr. So-and-so about this other problem, she said this, and we saw and you're the one who's conveying the impressions, that is okay. But if they happen to call the doctor and it's not exactly what you said, in other words, you're saying how you interpreted what your doctor said, it can get you into a situation where the attending physician caring for your child says, well, I talked to the doctor and he didn't say that. He actually said this. So so I would refrain from that. If at all possible, bring, if you get copies of your child's clinic notes or your clinic notes, bring the last clinic note with the relevant doctor, or if it's relevant to the issue, bring the last clinic note so you can actually just provide it. Get out of the habit of being the source of all medical information for your child. Yes, the doctors have to take a history, but where other doctors are concerned, better to show them or have them look it up on the medical record. Other things, be calm and diplomatic. It's hard to do. It's hard to do if you are if you've been awake for the last 2 nights because your child has been vomiting. If you're in a hospital setting, it makes you anxious. You already have your own things going on, your own work, and the rest of the family. Who's going to take care of them? But you want to try to be calm and diplomatic if possible. Validate how busy and pressured the staff is. Begin every question with, I know how busy you are. I can't believe you're here so late. I saw that you were here so late last night again. I hear you came in early. I can't believe how many patients. Validate. They want to be appreciated for all the work that they're doing, and they do a lot of work. And show your appreciation, again, with the thank you, with the, when my mom was in twice a week, I brought stuff for the nursing staff because it's working in a hospital can be brutal, and show them that you care about them as well. Advocate and be assertive. So it's good to be assertive, stand up and make your points clear, but don't be abusive. Even though you have every right to be abusive, every right to be aggressive if things are not going well. If you are, it'll only shoot yourself. People will just react to your reaction and you'll shoot yourself in the foot. And worse, some people, because of the way you act, will end up not paying as good or as much attention to your child. So, and granted, in a hospital setting, it's not easy. Oops. So the other thing is if you have bad luck with medical situations where you get into arguments, if doctors have fired you or your child, and then this happens because, there's not a good dynamic, then consult. And I have done this a couple of times with patients who are really knowledgeable. They are good advocates, but they got themselves into trouble. Sometimes, I remember one mother used to, the way she would talk and the way she would advocate, she would reduce interns and residents to tears. And so they were afraid of her. And in a couple of situations, a medical social worker actually ended up counseling her on how to make her communication more effective so that she could get across her points and engage the medical staff rather than put them off. So this is a hard subject, a hard situation. But don't be afraid to look at yourself and see what can I do to make the situation more effective. Anyway, at this point, I will take questions, and thank you for listening.
Thank you so much, Dr. Korson. It is hard as a parent to take emotion out when you're communicating. So these are all really good tips and things to think about. I know that I was the primary caregiver for my mother and father at when they were in later stages of their life and dealing with dementia and Alzheimer's. And it's tough. It's tough when you know that a physician might be, administering a medication that maybe that, mom or dad had a reaction to, and it could cause an issue and they're not listening. And it's hard to take the emotion out, but that's what you have to do. So we appreciate that. Just, take a deep breath and count to 10 and mix that. We've had a lot of comments and questions come in. So the first question that we have is, how often should the protocol letters be updated?
As a rule, it should be done every year.
Okay.
Yeah, should be within the last year.
And how do you handle if we have one mom asking if you have a protocol that they don't feel is sufficient for their child, and maybe there's some more things to add in? How do you have that communication and that conversation with your doctor to express what, some of the things that you've struggled with?
Okay. Well, it's very useful. I mean, it's useful for me if I'm drafting a protocol to find out whether or not it's effective. And so what the point that you're making is this protocol is useful. Thank you so much for writing it. See how I build in the appreciation every time you talk. But this didn't work for us because listen to our situations. This is what happened to us. And so it's give the feedback to whoever's writing the protocol saying what didn't go well in your situations. Could the protocol be amended so that we don't run into these situations again? And I personally would find that very helpful. I would amend it if it's going to keep somebody out of trouble.
Yeah, absolutely. So how do you handle engaging with doctors when you're out of state and they're not familiar with you and they may tend to be a little bit hesitant to listen to protocols, or even sometimes, like for college students, they may not even want to take on that patient because they won't be seeing them regularly. They're not familiar. How do you manage that? So
you mean as a primary care patient, not as an ER patient?
Correct.
All right. When you have a complex disorder, it is very useful to have a conversation early on with your primary care physician. And you may have had that primary care physician for years, but now you have a diagnosis that you didn't know about. It's useful to have a conversation when you're not sick and have a conversation about what you need from her or him, what you need her or him to do for you, what are the possible problems that can occur, and ask if that doctor is willing to take that on. Some doctors don't want that. They want healthy patients. They want to handle the ear infections and the vaccinations. That's all they want. They do not want complex patients. And it's useful. It may be disappointing for you, but it's useful for you to get that heads up, because otherwise you are going to get into a passive aggressive situation with them again and again when things get bad and they're not responsive and you get pissed off and they feel like they're uncomfortable. Just find out if they say they don't like that, then you have to find a doctor who is willing to take that on. And in fact, say thank you because they're being honest.
Right.
But if a doctor says, yes, I'm comfortable with complex situations, then maybe talk about some scenarios where you may need their help, whether it's to call ahead for referrals, to call the ER, to emphasize the importance of the protocol, to help back you up. And so definitely have that conversation up front.
Yeah, we talked a lot with the young adult group yesterday because we've had a couple of questions about college students. And what they shared is that before they even started school, but when they're not in a crisis, they went in and met with those doctors ahead of time, had those doctors communicate with their doctors at home, and so that they had a plan. Because, right, it's hard sometimes if that doctor's not familiar with your complex case to just walk in when you're in crisis. But to be prepared with a plan ahead of time and have those conversations, like you said, when you're not in crisis is really important.
Right. And afterwards, if you have a doctor who is willing to be engaged in that way, after a situation of a crisis, if you can get that doctor some documentation of what happened during that crisis, that will be useful. Because the way doctors learn is by experience. And if they have no personal experience because of their own training, then you have to provide some of the teaching material. And so that will be very useful for them.
Yeah, absolutely. So another question came in and says, what if your metabolic doctor isn't willing to pick up the phone and call the ER and help you manage the protocol letter and preparing the ER team to properly deal with your kid? What are the recourses that you have at that point? Not everyone is as gracious as you are, Dr. Korson.
No, well, it's part of the problem is in this little field of medicine we are understaffed, and there's a workforce shortage, and there's a lot of demands. I guess what I would do is I would say, who is there a person on the team who is willing to do this? A nurse practitioner, a physician assistant? Is there someone who can serve this role? And then if the others, I guess what I would do is, if there is nobody else, what are we to do in a situation where a doctor is not following your protocol and things are not happening quickly? Or what do you, metabolic doctors, suggest we do in that situation? It sort of puts, like, rather than you have to figure out how to solve the situation, you're really putting it back in his or her lap. Okay, you don't want to do this. What are we to do if people won't follow your protocol?
Yeah.
And find out.
Yeah, it sounds like you've got some rain going on there.
Say again?
Sounds like you've got some rain going on there.
No.
No?
Nope.
Okay. We hear a little bit of background noise. That's okay. The next question is, we've had a lot of questions about D10 and D10 not being readily available when a patient arrives at the hospital, but it has to be ordered from the hospital pharmacy. How do you manage that and help, so that you're not waiting, your patient's not waiting, that's what they need right away.
Right. Well, sometimes one could, most hospital settings, you can't simply add sugar to a IV solution. It really has to be the pharmacy that does that. Running 5% dextrose at twice the rate is the equivalent. You're just getting a lot more fluid. You're just getting twice as much fluid. So, patients who don't have a heart problem, who can sort of manage that for a certain length of time. You can't go days, and you shouldn't be going a day getting twice the amount of fluids. You're getting 2 to 3 times the amount of what you should be getting. But you can, for at least a short period of time, be able to tolerate at least twice the volume. The other thing is, if they are giving a bolus of fluid, that is a large volume of fluid over a short period of time because you're dehydrated, instead of giving normal saline, give 5% normal saline. 5% as a bolus is actually more than enough sugar, because it's being given a large volume over a small period of time. That is more than 10% dextrose in the amount of sugar going in over a period of time. So that will help provide at least some sugar, a lot of sugar, until they're able to get the D10. So avoid normal saline as a bolus. D5 normal saline instead. The sugars will run quite high, but it will only be up there for a little while, and then it will come down once they stop it. So it's okay.
Okay, that's good advice. We got another question about, if my child is a hard stick, at what point do I request someone else to come in and attempt to put in the IV?
Good question. I think probably most centers probably have a protocol. Some already say 3 times and that's it. You have to switch. You can ask them, if your child is a hard stick, let them know that from the get-go. Before they start it, tell them that, the last time, let them know that. Give them some data as to how many times it takes for your child to get an IV in place, or to get a blood stick. Because what they'll do is they may go right to their most experienced person early on, or in some cases they'll call the NICU nurse, the newborn ICU nurse, to come down, prepare them and hype it up a bit if it's a real problem. The answer to the question is I generally ask them what their protocol is. I would generally ask them what their protocol is, and so that it's very clear that after 3 times or whatever, they'll go to the next person.
Yeah. Okay. So the next, and this will be our last question before we run out of time. With so many very important ER multi-system diagnosis and medical issues and needs, how do you get a simple and needed protocol letter? I have so many critical diagnoses.
So, so let me understand this. Is it the question is for a complex disorder where there are lots of services, lots of issues, how do you get an emergency letter?
And I guess the question is, how do you get an emergency protocol letter, being able to address all of the necessary issues that this patient has without coming in with this overwhelming protocol letter that people are going to say, well, this is too much. I'm not going to look at this.
All right. Well, that's a really good question. Someone has to take control of the protocol. So, and if it's a metabolic patient, let's say with ELCAT or LCHAT or something like that, then I think it's most appropriate for the metabolic doc to take control of the protocol, just because, you know, some of the crucial issues, they're the only ones who are going to understand it the best.
Yeah.
So I would start with that as the basis protocol, and then have that, and then send it around to each doctor to add something specific. But ultimately, somebody has to look over it at the end to make sure it's not overwhelming. And I would leave that to the metabolic doc to determine.
Yeah.
Ultimately, protocols are good, but if they're not practical, and no one's going to follow them, so somebody has to determine that. And I think we probably have more experience with writing protocols than most other specialists.
Yeah, absolutely. Well, I think this might open the door, Dr. Korson, for us to continue and have some future conversations about protocol letters specifically for our community. Does that sound like a plan?
It sounds like a plan.
Wonderful. Well, we are so grateful for you. This has all been wonderful information. You will be joining us in a little bit for our physicians panel. So we'll have Dr. Korson back. If you have any additional questions, feel free to jump on and drop those questions in the Q&A.